Good evening to you all. We would like to welcome you all to this fifth international webinar that ZOS has hosted since the inception of the webinars some 3 months ago. Our guest speaker today is my mentor, Dr. Amiz Hussein. He's a consultant and head of retinal services in the Orbit Healthcare, which covers Mauritius, Madagascar, Mozambique, and Zambia as well. Formerly, he is a consultant via surgeon and head of community ophthalmology services at GE Institute in Cochin, India, where he was between 2010 and 2015. In terms of his academic qualifications, he acquired his MBBS, which is more like our undergraduate degree here in Zambia, at Annamalai University in India. And thereafter, he pursued his Master of Science in Ophthalmology, that is equivalent to our MMed here in Zambia, at the International Center for Eye Health in India. Thereafter, he proceeded to pursue a fellowship, a long-term fellowship in vitreoretinal surgery at GI Institute, which is Girida Eye Institute in India. And he's also achieved several other trainings in media, bioethics, clinical research, epidemiology, and research methodology. He is affiliated to several societies and associations, namely the American Academy of Ophthalmology, the European Society of Retina Specialists, the American Society of Retina Specialists, the Asia Pacific Ocular Imaging Society, the Vitreoretinal Society of India, the All India Ophthalmology Society, and indeed the International Council of Ophthalmology. When we look at his academic achievements, he is a 2020 International Education Awardee under the American Academy of Ophthalmology. He is also taken several publications nationally and internationally. He's received 12 awards for various scientific research works. And also he's a 4 times Best Image Tag winner in the American Society of Retina Specialists Image Bank. He has special interest in retinal imaging, diabetic retinopathy, and macular hole surgeries. And most importantly, and what I find very interesting as well, he has designed a novel macular hole index to predict outer layer restoration in macular hole surgery. I think having mentioned this, I would like to open the floor and hand over to Dr. Amiz. So if we have any questions as Dr. Amiz goes on, please send them through the chat box at the bottom there, and then we'll get back to them as the presentation goes through. Thank you.
Thank you, Dr. Kasangol. I think I'm audible to all. Good
Yes.
evening, colleagues, dear colleagues. I'm happy to present my work and about the autofluorescence imaging. I have been working on autofluorescence since 2010, right from my fellowship days. I have done some work, I have done some presentations and publication also. So when there was when Zambia Ophthalmic Society offered me to talk in the forum, so I thought I'll start with an imaging, which is my favorite area. So today, can I share the screen? Dr. David, can I start this presentation?
Yes.
Yes, so I'll share the screen. I think you can see.
Dr. Amiz, excuse me, sorry, is there a way that maybe the noise in the background could be reduced?
I think I've turned off the air conditioner now.
Okay.
Still the noise is there?
Yes, the noise is still there.
I really don't know.
I think the audio is still better than the noise that is coming. I think you can proceed if we can't get rid of it. The voice is audible.
Okay, I'll proceed, or Is it disturbing you a lot? Because
You can
I'm
please
inside a
proceed.
room quite, yeah, okay. So
Please proceed.
I think you can see my presentation, right?
Yes.
Yes. So thanks for the introduction, Dr. Kasangole. We'll proceed with the presentation. So Fundus, this is my disclosures. Fundus autofluorescence imaging is a imaging modality which has been under research from early 2000s and came into existence in the late 2000s, like a prototype. And then the Heidelberg engineering has taken it to a different level with very high quality uh, images from this imaging modality. So if you see autofluorescence in the Wikipedia, you get a definitions like this: is a natural emission of light by a biological structure such as mitochondria and lysosome when they have absorbed light. So clinical applications of this imaging has been in the field of medicine for a longer time now. So it can detect early malignancy in the GI tract, the respiratory tract, etc. In genetic engineering, they use in plastic and reconstructive surgery, they use this imaging technique, molecular level research, and some laboratory tests. And in ophthalmology, we use it for imaging the retina. Now, a few examples of other clinical applications other than the eye. So here you can see it has the ability to detect. See the autofluorescence. This is a normal picture you can see here. This is the autofluorescent image where you can detect the pre-invasive lesions in the the carcinomas in the large airways. This is one application of autofluorescence in respiratory tract. And this is about the GI malignancy. You can see the lesions, the malignant lesions appear as hypoautofluorescence, like they reduced autofluorescence in an autofluorescent image. So they used to demarcate the area of malignancy in a GI tract. Now coming to the retina, there are unique features of this autofluorescence. One is that it is a non-invasive imaging technique, like doesn't involve any injection of dyes, or it's just like an OCT. You make the patient sit in front of the machine, and the machine, if somebody has, if residents are there, if they have not seen, the machine is like just inside the OCT. Nowadays in all machines there is an option whether you want to add an autofluorescent imaging also. You have to pay extra for that, and it is included in the OCT machine. So almost all OCT machines like Topcon, like Heidelberg, like Zeiss, everyone has got this autofluorescence imaging inside their OCT machine. So it gives an insight to metabolic activity in the retinal disease. It's otherwise called metabolic mapping. And the source of autofluorescence like blue spectrum, preferably ranging from 500 to 800 nanometers. And usually the one which is of high quality, like Heidelberg, they use the 488 nanometer excitation laser. So they'll excite this, and then it is captured by a emission filter between 500 to 700 nanometer. So this is the physics part of it. Now I'll show you with animation how it is done. So you just excite the retina, the area of interest, with this blue laser with this particular frequency wavelength. And then if you see, this is a picture of geographical atrophy. You can see a central reduced autofluorescence area and then a peripheral ring of increased autofluorescence. So this is a classic picture of an autofluorescent picture of a geographical atrophy. Now in this next video, you just see how it is done, how we got the image, how we get the image. So this, you know, the section of retina, you can see the photoreceptor layer, the bottom layers. And if you see the outer segment disc is periodically degenerated. And you can see this degenerative material, and it is engulfed by the RPE. So this is like lipofuscin deposition in the RPE. So normally it happens to all of us. This process is there for all of us. And there is a balance between the release of this degraded material and the removal of this degraded material. Like that's a balance. So even the balance is gone, like in some disease, like dystrophies, like some degenerative diseases, like age-related conditions, then what happens? The more of the removal of this substance is less, accumulation is more. So then what happens is that all this lipofuscins keep on get accumulated in the RPE cells, like shown in this animated video. And then when we do an autofluorescence, you get a picture like this. So that's what the lipofuscin is, what is giving the bright, the increased autofluorescence. And the center part is actually a degenerated area or RP atrophic area, which doesn't have any RPE. So it will be reduced autofluorescence. Now this is a normal autofluorescence picture. It looks like an angiogram, but you see the difference. See, the blood vessels are dark, the optic disc is dark, and then it is like a grayish tinge to the retina and the choroid. And you can see reduced autofluorescence in the disc because there is no fluorophores which can produce a light. In the arteries and veins, you have blood, so the light will be absorbed by the blood, so you will not get an autofluorescent emission back from the blood vessels. And if you see the fovea, the presence of luteal pigments absorb this light, so you will have a hypoautofluorescence or reduced autofluorescence in this area. So this is a normal picture of a fundus autofluorescence imaging. Now there are two conditions how you are going to study the image. So it is studied as a normal autofluorescence, reduced autofluorescence, and increased autofluorescence. So reduced autofluorescence, as I told you, when you have low lipofuscin levels in case of atrophy, because RP is a cell which lipofuscin is, and if it is not there, it will be low reduced autofluorescence. Retinal dystrophy, same thing. The cells are destroyed. No question of emitting the autofluorescence from the cell. And sometimes blocked RP. If RP is blocked by hemorrhage or a scar or a calcified drusen, then also you will have a reduced autofluorescence. Now, increased autofluorescence happens when you have increased lipofuscin, like RP hypertrophy in some diseases, increased accumulation of lipofuscin in some diseases like CSR or any other degenerative conditions. You get increased accumulation of lipofuscin. And in some cases where drusen, PED, all intraretinal, subretinal heme, choroidal melanoma, in all this condition, there is increase in fluorophores. Fluorophores are the degenerative material which can emit light. Lipofuscin is one of the fluorophores. So these are the conditions where you get an increased autofluorescence. Now I'll come to the clinical applications. So mainly we see these kind of diseases, macular telangiectasia, macular dystrophy, drug-induced macular. So these are the some of the important disease where we can apply this imaging device. Now this is about a case of CSR. If you see, there is a serous macular detachment here, and when you take one, and you can see the autofluorescence here because of the accumulation of the lipofuscin of fluorophores. So in increased fluorescence. Now, if fresh case of when you autofluorescent image, you will not get any kind of increased autofluorescence because there is no degeneration yet. But after 3 months, usually I have seen in my experience, after 3 months, it starts developing. So when you see an autofluorescence with this kind of an image where you can see the hyper-autofluorescent area, you see the whitish area here, hyper-autofluorescent area, that means this case has this disease for more than 3 months at least. And the more the dense areas of auto-hyperfluorescent area, that means the disease is for a longer duration. So for me, this is another, just not to detect the areas of previous CSR areas, but then I can have an idea of the chronicity of the disease also from the images, autofluorescent images. Now, long-standing CSR, as I showed you, see, it's a large patch with some areas of decreased autofluorescence. That means RP is dead, like very chronic disease. And some areas has got increased autofluorescence, white areas. That means these are RP cells which contains, the disease is active and which contains, is not still dead, it contains lipofuscin level, which is very high. Now coming to dry AMD, which is very commonly used, this device is very commonly used in Europe because they have very high levels of, very high incidence of dry AMD, and it helps to identify and precisely the area of atrophy. That is very important. And then progression, how it is progressing, how fast it is progressing. I'll show you some slides which will tell you this. Now, this is a picture. If you see, there are some, RP mottling are there, some drusen's are there, but doesn't look like that bad. But when you see the vision is quite bad. Why? Because autofluorescence shows that there are areas of definite atrophy. You can see the dark hypo-autofluorescent areas, which shows that the RP is already there. It's atrophic. So you can really study, when you have it, when the vision doesn't correlate with the clinical picture, and you can take an autofluorescent and see how far the RP is atrophic. Now, this is another area for geographical atrophy, another example where the established geographical atrophy. And this is the progression. You see the baseline image. You have an atrophic area of this much at the macula, the fovea, and then across 4 years, you can see each visit, you can actually mark the progression. So quite fast progressing geographical atrophy in this case. So this is identification, atrophic area identification precisely, and this is progression can be done with the autofluorescent imaging. Now, wet age-related regeneration has got limited insight because angiogram gives definitely a better view of the CNVM, but in autofluorescent image, the area of CNVM is shown as a hypo-autofluorescent area, decreased autofluorescence, because the CNVM will block the RP and the emission of the autofluorescence. So this is how we see a picture of wet AMD in autofluorescence. Now, this is a case of macular edema. You can see the petaloid pattern here because of the accumulation of the fluid in the endothelial layer. Yeah, this is optic disc drusen, where you can have an hyper-autofluorescent emission from the disc. See, when you have clinically, sometimes these optic disc drusen is very confusing. I think all of you are aware of it. So we will take a B scan to see, and sometimes it confuses with papillary. But autofluorescence is one imaging technique which will give definite diagnosis for optic drusen. So this is one definite diagnostic value for this imaging technique, autofluorescence. And this drusen, which because of its calcified areas, appears as a hyper-autofluorescent area in the disc. Yeah, and this is a macular hole, how it is seen. The center part is hyper-autofluorescent because there is no RP, so it is hyper-autofluorescence here. And RPE RIP, when you have confused, you can actually correlate with the fundus autofluorescence, which shows that RIP area is hypo-autofluorescence because the RP is ripped off, and the rolled edge will be hyper-autofluorescence. And this is in dystrophies. You can see in Stargardt's disease, the outer hyper-autofluorescent area and inner hypo-autofluorescent areas. And here, which is this is bullseye maculopathy, this is Stargardt's disease. You can see the flex. So the resolved flex will be hypo-autofluorescent, and active flex will be bright hyper-autofluorescence. This is a bullseye maculopathy. You can actually there are different papers which shows that bullseye maculopathy is earliest detected with fundus autofluorescence. And in some dystrophies, I'll show you. See this picture. It is just like a normally, if this case comes to me, I'll just see that okay, some focal RP atrophic areas, some pigments on the retina. But then when you do an autofluorescence, you see it is actually, we can actually diagnose the dystrophy very easily because of this pattern. So it's a pattern dystrophy, which is much clearer and definitely depicted in the autofluorescent image. Now, this is my case of retinitis pigmentosa. So this is, if you see retinitis pigmentosa, it's a clinical diagnosis, nothing much. But then autofluorescence will give you the area of viable retina, which is not affected. So a 45-year-old male comes and asks me how much I'll see, how many years more I have. If I take an autofluorescent image and I see that this much is there, I can definitely tell them, yes, you are going to see for many more years because you have a viable retina, which is quite enough for more years. So that's for this autofluorescence imaging in this retinitis pigmentosa cases. And this is a angiogram, fluorescent angiogram of a serpiginous choroiditis. And you know that, clinically, we may not be identifying the active part of the lesion. Angiogram definitely shows that, this hyperfluorescent edges, definitely this part of the lesion is active. But a person who we cannot do an angiogram, and, very simply, we can do an autofluorescence, and you can see this first picture is active vision, which is hyper-autofluorescent, and with the therapy, and this is getting hypo-autofluorescence. That means it is getting settled down. So here, this machine has got, this imaging has got a value where you can adjust the treatment. If you see that this area, the active area has become already atrophic and it is hypo-autofluorescent, we can actually taper the medication like cortisone or whatever we are giving. Now, this is another case of APM PPE. Here, this is a first visit, and you can see the OCT. There's definitely a serous sanguineous fluid here in the retina, and this is the image. And autofluorescence at the beginning shows that there is a hyper-autofluorescence along, I mean, in correlation with the fluid collection. And when after the treatment, you can see already the RPE atrophy sets in, and this is the point where we can slowly taper the steroids. So again, value for tapering the medicines like treatment strategy, we can, to plan this treatment strategy, we can use the autofluorescence. And macular telangiectasia, which this is an area which I'm very fond of. Is I have done some 25 patients with autofluorescence and spectral dominoes. And here, before I could publish, somebody had published. So I'll show you this picture. This is an autofluorescence of a macular telangiectasia. You can see the OCT. Now we all know that definite diagnostic modality for detecting the macular telangiectasia. Here you can see a stage 4. You can see already the pigment is there, and then here you can see the destruction of the outer retinal layers. Now this is the left eye of the patient, and left eye, you see it's a perfectly normal retina here. There's absolutely nothing, no evidence of macular telangiectasia. But you see the autofluorescent image here. Temporal part is a bit hyper autofluorescent. So that means before we could detect it from any other imaging modality or clinically or with OCT, autofluorescent images the lesion here. So this, by the time I published at that time, I think 2013, some colleague from Belgium or someone, that part of the world, they had already published it. So now another case in diabetes. I'll show you how autofluorescence helps me to diagnose a special interesting case. A 53-year-old male with defective vision 1 week, just 1 week, 15 years old, 15 years diabetic. Right eye is 6/9 N8, left eye 6/36 N36, quite a significant loss of vision. And this is the right eye angiogram, you see. It's a classic picture of a severe NPDA. You can see a sursate here, some blood hemorrhages, angio, some leaking, and some diffuse edema everywhere. So, but then the vision is 6/9 N8, not much. And left eye, less findings than the right eye. You can see one sursate here, but you see very less leaking aneurysms and very less diffuse edema. So why the left eye then it is very, vision is very less. Now we did an OCT, we see that in the right eye we can see the spongiform type of edema, the cystoid type of edema, and the serous detachment also. So all three confused. Why? Because diabetes, yes, we can get serous detachment, but then the retina, no intraretinal changes like the other eye. Now we did an autofluorescence, and there we see the large hyper autofluorescent patch, like in CS. So there is an additional central serous retinopathy for this case. The right eye away from the macula, so vision is fine. The left eye, the active disease is here, and you can see the autofluorescence are setting in. So this is how, in some difficult cases in diabetes, when you see those doesn't correlate with the OCT or the angiogram, you can do an autofluorescence and see whether we have any or degenerative. The case from my mentor, Dr. Storangi from University of Milan. So this is a picture he published in Heidelberg Academy. This is a choroidal rupture. You can see very clearly a closed globe injury with a choroidal rupture. Fine. But then what is the autofluorescence giving? It's giving a picture like this, a definite picture showing the cracks, like some earthquake and a crack is there. Very beautiful picture and exactly showing the area of rupture. So it's a fantastic picture I've ever seen with the fundus autofluorescence imaging modality. Now, this is a very interesting case of mine where I have contributed to the use of fundus autofluorescence. So this is a case of hemicentral retinal artery occlusion. you can see the half of the retina is affected. There is a serioretinal artery sparing, luckily for this patient, young patient. So he doesn't have any systemic history when we ask. Nothing is there. Everything was fine. I don't have any problem. I don't have any heart problem. I don't have any other issues. Very individual actually. If you see, and he was saying that there is no problem with him systemically. Now this is a more closer picture of this retina, and here you can see at the disc there is something there in white. And if you carefully see, yes, you can see an embolus here. And I decided to do a multi-modal imaging for this disc. So I did the red-free imaging. That embolus is not seen very well. Yes, it's seen, but very well. But you can see the area of artery occlusion, and you can see the closer look. Yes, and now this is the angiogram where you can see the serioretinal artery sparing, and you can see the embolus much more clearer than the red-free. You can see it clearly. Now I did the infrared imaging. No, it's not clear. You can see that it is like a little bit dark here along with the area of occlusion. Now this is the autofluorescence imaging, which is just highlighting that embolus. You can see it is like an LED bulb on the disc. That much is hyper autofluorescent. Now, after seeing some literatures, I decided to send this case to a cardiologist. What literature I found, I'll tell you later. So I straight away, I assumed that this is a calcium emboli after doing some literature work. And then, because you know that calcium emboli, mostly it is from the heart. So I sent to a cardiologist. And the cardiologist found that he had a severe calcific aortic stenosis. And then his mother is saying that, yes, he had some problem in the childhood, which was okay. Then we never went to a cardiologist. So it's like ignored case of a heart condition. And he was advised a aortic valve replacement. So through the eye, we have diagnosed a systemic condition, which was quite significant for that young fellow. And yes, hemiretinal central artery, hemicentral retinal artery occlusion is rarely described. And it can be because of thrombosis, vasculitis, embolic impaction, vasospasm, etc. And if you see, it can be either a cholesterol deposit, Hollenhorst plaques, calcium, fat, parasites, air, anything it can be. And calcific emboli means it is very usually from a cardio or valvular origin. And then fibrin is mostly from fibrin or cholesterol plaque is mostly from the carotid arteries, where you do the carotid Doppler test to find out whether there is any block in the carotid artery. And as there's some information to the residents, I know it's most of you will be knowing all these things, but then for the residents, I would tell you that emboli can be seen mostly in around 20% of the patients with CRAO. If you look for it, you have to carefully look for it. For example, this case, if you will do that, because you just see the area of occlusion, you have to see the disc or any artery for any emboli. You see it with for younger youngs, the emboli can be seen in 20% of the cases. And now I did some filtration that high autofluorescent proper material. I just decided to type in the Google that material has hyper autofluorescent property in a blood, very publication, like I think 1978. He had studied the fluorescent property of a calcified sample in an artery. It's 4 times more intense. So that's how I concluded that embolus must be a calcium one, because of this 2-3 articles I read. And then another report was there in choroidal osteoma also. It usually gives a hyperautofluorescence when you have, because that's a calcified calcium tumor, you know that. So now this is a image. I have just compiled everything. You see, compare the imaging modalities like photograph, red-free, fundus fluorescent angiogram, near infrared. This is 3D OCT, and then the autofluorescence. So this is a very definite diagnostic image, that if you see this kind of an image in a retina, autofluorescent image in a retina of artery occlusion, you can tell that it's a calcium embolus. And I gave, because it looks like an LED on the disc, I gave this sign as an LED sign, and we could publish it in a journal in 2016. So that was my contribution to the autofluorescence imaging. So I think I have taken a lot of time in the presentation. Thank you for all of you for the patient listening. Thanks a lot.
Thank you, Dr. Ramiz, for that wonderful presentation.
Thank
And
you.
you kept very much to time.
Oh, thanks. I was wondering whether I'll finish because
at least it leaves us room with some questions. I'm sure we have a lot of questions from the audience. And just to mention also that fundus autofluorescence is not a far-fetched thing among us. The fundus cameras that we have in Zambia at most of the centers have that option for fundus autofluorescence. So it's something that we can explore and bring into our practice. I'm sure of the machine which is at the UTH and the machine also which is at Lewanika. And I think those are prototypes that are also in Kitwe and in Dola. So
well, that's fantastic, huh? Fantastic.
Exactly.
Nice. Yeah.
And for me, clinically, I find the importance of FAF when you're following up a patient who has got choroiditis.
Yep.
Because you're able to tailor the management and know when the lesion is active and when not is active. Because usually when you just look at the fundus photo or when you do your funduscopy, you won't easily tell that this lesion has healed. This is now a scar. Because just within that scar, the edge of the scar is where the activity of the lesion is. And that can only be seen when you do a fundus autofluorescence imaging image. So I would like to encourage everyone to try and make use of this option that these machines have. And as always, we can always consult and share the knowledge with each other. Dr. Mumbi, do we have any questions on the other side? So as we're waiting for the other questions, just to add in also. So like Dr. Amiz had shown in the presentation, that autofluorescence can be used to follow up GI tumors, GIT tumors, and so forth. And similarly, besides the retina in the eye, other structures in the eye can also autofluoresce, like the cornea epithelium, the cornea endothelium, the lens, the optic nerve, and so forth. But the design that the fundus cameras have, they've been designed in such a way that there's an excitation filter that allows for the fluorophores to emit their energy, whereas at 488 nanometers, and at the same time, the machine is designed with a barrier which blocks the autofluorescence from all the other structures in the eyes, such as the cornea, and so you don't see them. You only see the autofluorescence coming from the retina. So very exciting stuff.
Yeah, I think this is one imaging modality which we all are underusing. Even if we have, we really don't know where to apply it. But I suggest that, whenever there is an interesting case, especially in a teaching institution, we should try a multimodal imaging, like, try it from the fundus photo, then the red free, then an infrared, and then, because OCT machine has infrared, because in the side corresponding to the scan, you get an image. So some machine is infrared, some machine is red free, some machine it is a scanning laser of imaging image, or some machine it is NFAS image. So everything we should try a multimodal imaging, and then you will find something unique, something new. That's what I feel, especially residents, by PGs, postgraduates, you try and see how to use this machine much more effectively than right now.
Any questions from Kitwe? Dr. Chupa? I can see you've been very attentive. Dr. Moka? Have we checked if the machine in Kitwe has that modality for fundus autofluorescence? Normally you have an abbreviation on the machine which says FAF.
I think they're mute. Then we have to unmute to talk.
Yes, Dr. Kasongoli. I think most of the information that we have learned today is new. So for me, I was actually planning to go and check tomorrow to pay more attention to the other functions, because we normally just use the fundus photography. That we use just the plain one. I think we don't go into so much detail, but it's been an eye opener.
Case. I think our machine is able to do that, but we confirm. Wonderful. Yeah.
Images. Like for example, if you have got a red free image and then you also have a FAF image. So in a red free image, the disk will appear bright, okay, as opposed to the hyperautofluorescence that the disk will have on a FAF image.
Okay, thanks. Mm-hmm. And there are some no, just for somebody who wants to try autofluorescence for some research, or to take, as Dr. Bisa and Dr. Moka was saying, if they want to try, I think there are a lot of online videos in academy, and there are some PDF books also. I think it's free for download. If you can see, they have the atlas, and then when you see, you can always compare and see whether it is similar, because some dystrophies are very confusing, especially the dystrophies. So it seems to be like everything is same, but autofluorescence have definite definitions for these dystrophies. So very amazing imaging modality for retinal dystrophies and degenerations. So those atlas, if possible, you can get download from the net. Many of the sites have free downloads. This retinal autofluorescence atlas.
Thank you for that. Thank you for that information, Doctor. I'll definitely do so. Probably it could help if you could also just maybe type the title of the atlas in the chat box.
Yeah, right now I don't. I'll just send it to Dr. Kasangule later, because right now I don't have it. The link. I'll give the link to Dr. Kasangule.
All right.
He can WhatsApp you. Yeah. Okay.
Thank you.
Dr. Mumbi, are you still there?
Yes, Dr. Kasongole. Sorry, I was traveling.
Oh, okay.
Yes.
Happy to see, if I may just mention, Dr. Asane from Mozambique is one of our biggest fan of the webinars. He's always there. It's good to see you. Any experience with
Thank you.
FAF imaging in Mozambique?
In my center, I don't have those machines. I'm in the bit rural area. I don't have the machine. Then no any experience. Say, perhaps in private sectors, in the public sectors, only in the output, which is the place where we have one private sector in Algawal, perhaps there. I'm not sure.
Yeah, I think I have visited the central hospital in Maputo. They have a lot of gadgets. I think they have a machine which has fundus autofluorescence.
Any other comments? I think if we have no other comments and questions, I would like to take this opportunity to thank everyone for having attended today's presentation, and many thanks to Dr. Amis for having found time to share with us his rich experience in fundus autofluorescence. We will see more of Dr. Amis perhaps in the next 2 months. He will do another presentation on,
Sure.
yeah, and we're able to share with everyone. Dr. Mumbi, you're there? Any last few words?
Yes, Dr. Asongole, just thanking Dr. Ramiz for sparing time and sharing us with us. There's one thing that I've seen, what I've realized. I believe in hearing and also becoming exposed to as much information as possible in ophthalmology, because at a critical time when you are confused with the diagnosis, unconsciously you order some investigations that really help and can also can be life-saving, as one of the examples that we saw in that patient that Dr. Amizi made a diagnosis and referred to the cardiologist. So just aging everyone as much as possible, not only for getting CPD points, but this is really to improve your quality of care for the patients. So for the next series that we are going to have, we are going to communicate with him. Otherwise, we continue as per shared schedule that we did. So Sundays, if at all we have a presentation on Sunday, we will inform you. Otherwise, so far we only have 2 presentations that are going to come on Sundays, and this is in Konya. So for the rest of our colleagues who have joined us from Zimbabwe, kindly continue participating. It's something that you will benefit in your practice and also in training and sharing with the colleagues back home. Thank you. I don't have any more words.
Thank you, everyone.
Thank you. Thank you so much.
Good evening.
Bye. Good evening.
Thank you and good evening. Bye.
Thank you. Bye.